You've brought up calcium scores, angiograms. Let's go into different forms of testing and where those might be beneficial.
Yeah, so I think I try and keep it simple. Unless there's somebody got very unexplained symptoms or they develop heart disease prematurely and you haven't got an idea, then I wouldn't go right in any. I'd keep it very simple. Your basic fasting cholesterol profile, triglycerides, HDL, total cholesterol, LDL. Although to be honest, you probably don't need to measure LDL and total cholesterol. It's just for interest sake, right? That's what we want to look at. And your triglycerides should be, and you'll have to help me here a little bit, Jesse. I'm trying to remember. I think in the US terms, it's less than 150 milligrams per deciliter. In UK, it's less than 1.7 millimoles per liter. I think that's the equivalent. And your HDL should be above, again, I think it's, if I'm not wrong, in the US units, it's more than 50, but you can calculate it. For UK, it's more than 1 millimole per liter. Ideally, you want your triglycerides less than your HDL. So the ideal way of looking at it when you convert to millimoles is triglycerides are less than HDL. And if your ratio is more than 4, that's at your highest risk, and less than 1 is lowest risk. So that's what you want to measure there from the cholesterol profile. And then the blood test I would recommend, the other blood test I recommend is HbA1c to make sure you're not pre-diabetic. So you want your HbA1c to be less than 5.7%. From 5.7 to sort of 6 is considered pre-diabetic, or 6.5, and then above 6.5 is type 2 diabetic. But these are, again, all reversible or improvable. I would measure blood pressure, and blood pressure ideally should be less than 120/80. Between 120/80 up to 140/90 is what we call pre-hypertension. And your risk starts to increase gradually for stroke as that increases, and heart attack. And then you want to measure your waist circumference. But actually, rather than get into the weeds about actual what measurements, I think a very useful tool is your waist circumference should be less than half of your height. So if you're 180 centimeters tall, just under 6 foot, you want your waist circumference at the belly button to be less than 90 centimeters. And if all those are normal, I think you're in great shape from a heart disease perspective.
Talk to the angiogram, coronary calcium score, stress tests, some of these advanced tests that people might be getting.
Yeah. So let's start with stress tests. So traditionally, okay, let's take a step back first and foremost. A good doctor makes his diagnosis mainly from the history. And that is a conversation with the patient. A bad doctor orders tests without speaking to the patient or taking a good history. Let's start there. And the reason for that is 80% of the diagnosis, Jesse, comes from the conversation, right? The symptoms the patients are describing, there are certain patterns that have been recognized over centuries, decades at least, but centuries, that fit with the likelihood of a disease process. When it comes to heart disease, and we'll get on to explaining what the stress test would be helpful, the classic symptoms are of angina, of a blockage, not an acute heart attack. And acute heart attack, we'll just talk about acute heart attack actually. So this is where people should be worried. An acute heart attack is classically a central heaviness or crushing feeling lasting for, more than 10 minutes, associated with sweating, sometimes radiating, traveling up into the neck or into the shoulders. And that is a red flag. And that is when you call 911. All right. A milder form of that is what we call angina, which is a patient comes in and they say when they're doing exercise or they're stressed, they feel the same tightness or squeezing in the center of the chest, not on the left, not on the right. It's a tightness or heaviness. And it's then relieved by rest. And those, depending on how severe and how often they are coming, that's when you would potentially do a stress test. Sometimes you do a stress test if people have atypical symptoms. A sharp pain, a stabbing pain isn't necessarily in the center. And that's when stress test becomes also helpful as an exclusionary tool. And that the traditional test would have been an exercise treadmill test. You get an EKG, put people on a treadmill, you get them walking briskly, getting their heart rate up to what we call 80% of maximum target heart rate. So that's 220 minus your age and 80% of that. So if you are 40 years old, for example, 220 minus your age is 180. 80% of that is let's figure 18 times 8, right? So it's 180 divided by 10 times by 8. So 18 times 8, 64 plus 80 is 144. Sorry, I just did it in my head, right? So you want your heart rate to get up to over 144 and you not get chest pain and the EKG to be normal, not show changes. The different changes you look for, SC depression, for example, right? So that is a positive treadmill test, which would suggest a significant blockage of over 70%, in which case the gold standard test to look for that is a coronary angiogram, which is injecting dye, takes about 20 minutes. You pass tubes up to the heart, use x-rays, patient's awake, local anesthetic, and you inject dye. So I did thousands of these. And that tells you that's the gold standard to look for any significant blockages. The more useful test than one of the problems with an exercise treadmill test, Jesse, is what we call false positives. And they have up to a 50% false positive rate. So that means that the test looks positive, but the ultimate result is that there's nothing wrong. And that can cause anxiety, et cetera, et cetera. So you've got to use the test appropriately. What would be better than that, it's obviously more expensive, is what we call a stress echocardiogram, which is where you do an ultrasound scan of the heart and you get people on a treadmill or on a bike. And then you when your heart rate gets up above 144 in this particular patient, you look at the heart muscle and you see how it's pumping. And if there's a blockage, the heart muscle stops pumping as well in the area of the blockage, where the blood vessel is supplying. So that's what we call stress echo. That's non-invasive, again, very safe, quite a useful tool. Calcium scores are usually done, Jesse, in patients that don't have typical symptoms. Patients you're not predicting have got a significant blockage. Because if you're predicting a significant blockage, you should go straight for an angiogram. But with a calcium score, it's now used as a risk tool, like checking your cholesterol or checking your blood pressure. And actually, I would say I'm a bit biased because I use them quite a lot. And by the way, declaration, I'm not getting paid to promote calcium scores by any device company, just so you know. It's important for me to mention that. But I would say that many people, if not most people, over 40 these days, if you're a man, and over 50 if you're a woman, because the validation of the test really is only in those groups. Because you can miss soft plaque in younger people. It's over 40. If you're a male over 40 or a female over 50, calcium score is great if you're worried about heart disease. And the reason why it's also so useful is it gives you a score anything from 0, which is normal, to over 1,000. Less than 100 is what we call low risk of a heart attack or stroke in the next decade. 100 to 400 is moderate risk. More than 400 is considered high risk. So it's a great snapshot tool. It can be repeated, not more than once a year because of radiation. But you can then see from an intervention, if you have a calcium score done, let's say it comes back at 250, and you're like, whoa, no severe blockages, not high risk, not low risk. What do I do, doc? Here, go on my protocol. Let's repeat it in a year. And then you will see that the calcium scores remain stable or even improved, maybe reversed. And then you can be confident that what you are doing with your lifestyle is actually having an impact. And I think that's a great way of using the calcium score as well, serially, to see and to reassure patients that what they're doing is working.
Let's talk more about the soft plaque versus hard and tie it back to the pimples we were talking about before. When does plaque solidify and become calcified? And then we can go from there.
We don't know for sure, Jesse, on that. The presumption is over time, it can become calcified because the calcium is a response to the inflammation. So it's probably something that happens over time. It probably doesn't happen quickly. I think soft plaques develop more earlier on. I don't know. I haven't seen data on serial looking at when the soft plaque becomes a hard plaque. But my experience doing angiograms, you just see these people that have usually had coronary artery disease for many, many years. They're more likely to have more calcified plaques. And in theory, and likely in practice, the calcified plaques are more stable and less likely to rupture. They're also the hardest to stent because a stent isn't removing the plaque. When you're putting a stent in, you're putting you're passing a balloon, a deflated balloon on a wire in the middle of where the blockage is, and you're inflating this balloon. right? And if the balloon doesn't inflate on a calcified plaque, sometimes the balloon actually bursts because the calcium is so hard, and that theoretically means that plaque is probably not going to rupture and cause a heart attack because it's now stabilized and it's covered in calcium. It may be causing angina, and that might be why you want to put a stent in, but it isn't going to cause a heart attack. So in many ways, a calcified plaque is a more stable plaque and the more reassuring plaque. The soft plaque develops earlier. It doesn't have because the pimple bursting is related to the outer layer, if you like. If it's very thin, right, it's like it's more likely to just burst. Whereas if it's thick and hard, that's when it doesn't tend to burst and cause exposure of its contents of the plaque, the immune cells, the LDL, oxidized cholesterol, LDL, to the blood, which then causes the bloodstream to see foreign body, toxic, I'm going to form a clot there. So that's how the clot forms and then can completely obstruct the vessel.
Would it be fair to say that the calcified plaque is older pimples that have solidified and become more structurally sound?
Yes. But the reason people are going to say, but hold on, that doesn't mean a high calcium score then is good. No. The more calcified plaque, the more soft plaque you have.
Okay. So there's a correlation there.
It's a surrogate marker of soft plaque.
And there is potential to reverse a calcium score. You quickly touched on that.
Yeah, it's interesting. I think a calcium score, I've seen that happen in some of my patients, but soft plaque, certainly one of my patients had a carotid. The same process in the heart arteries happens in the neck vessels, which, go to the brain. And if they cause blockages there can increase the risk of stroke. One of my patients, and it was pretty extraordinary, Irish lady, a few years ago, she followed my protocol, except her stress levels had come down by some other means, but she didn't do the meditation, just a diet. And she had a 75% blockage in one of her carotid arteries, having had a mini stroke. And 5 years, she emailed me, went to the same lab, the same radiographer that did the ultrasound. 5 years later, had gone less than 25%. And she said, "Thank you, Dr. Malhotra. I've just followed your plan." I was like, wow, that's amazing. It's just one patient. It's an anecdote, and it could be coincidence. But I like to think that, the plan I recommended probably played a role.
Speaking about the carotid arteries gets me thinking about CIMT. Isn't that an ultrasound that can be done on those?
Yeah, that's looking at thickness of the carotid artery, and that can be a precursor to blockages developing. I think if we've got access to calcium scores, Jesse, I don't think it's of any use to do a CIMT. I think just get the calcium score done. Because you can have people with a normal CIMT and have got a raised calcium score. You can have people with a thickened CIMT have a normal calcium score. The calcium score is most validated in terms of predicting events in the future, as far as I'm aware, not the CIMT.
As a cardiologist, are you aware of this talk of an ear crease on the earlobe and that being associated with certain heart conditions?
I'm aware of it, Jesse, but you probably know more than I do right now about it.
I just know there's some kind of association. I just wondered if
there's
anything to be concerned if somebody's looking there.
Yeah, I'm not. I won't be able to quantify what that risk is, but it's a marker definitely of heart disease. So if somebody has that ear crease, then yes, they should be investigated, and probably a calcium score would be the thing to do.
Since you made it to the end of this clip, I know you're going to love the full episode. Click here to watch. I'll see you over there.
I trained as an interventional cardiologist. I love solving puzzles. When you've eliminated the impossible, whatever remains, however improbable, must be the truth. Guideline bodies still say that LDL cholesterol is the primary causative risk factor for heart disease.